1.32%. And also sir has now talked about blood transfusions. So blood transfusions itself is also causes increased risk for perioperative sepsis. In post-operative period, there are challenges many to say for even detection of sepsis in these patients with underlying cardiac dysfunction, and how to treat sepsis in these patients with cardiac dysfunction. So to first, in assessment of sepsis risk in cardiac patients, the important pre-existing cardiac conditions we have. The common one, ischemic heart disease, increases the odds ratio by around 1.3 to 1.5%, while the presence of any heart failure increases the risk by around 1.8. So it almost doubles the risk of sepsis in these patients. But the most important risk factor which has the highest odds is actually the right ventricular dysfunction. So the presence of a right ventricular dysfunction increases the odds ratio to almost 2.32 times the normal patients. So what are the limitations for the risk model? So normally when you look at the perioperative risk, we have talked about some of the risk factors. We have the RCRA score, which we commonly use, but they lack key variables when it comes to determining the risk of sepsis in the perioperative period. So you need to have at least ejection fraction, lactate, and some of the things to actually improve. There are risk models which are rarely used to assess for the preoperative models. So also we have some of the biomarkers that are now available that can help us in stratifying the risk in these patients. We have procalcitonin, CRP, which are included in some of the risk factors. We also talked about D-dimer, neutrophil lymphocyte ratio as a marker of immune status in the perioperative period, and also the cardiac reserve by using troponin and proBNP. So all this combined with clinical factors can actually give us a multimodal risk stratification with the help. So these two new models are now most appropriate, I would say, to assess the perioperative sepsis risk, classed to be the common, especially when it comes to emergency surgeries. For elective surgeries, AUB-HAS2 also can be used when it comes to assessing the perioperative sepsis risk. When you talk about optimizing the perioperative risk, the pre-op time, most important is also pharmacological and also functional optimization. Nowadays, most of the patients are on SGLT2 inhibitors, and this is becoming an increasing risk factor for the perioperative mortality and perioperative sepsis, especially when they land up in emergency situations. So it is always better if you can stop SGLT2 inhibitors at least 3 to 4 days before an elective surgery. And also you need to continue statins, beta blockers, especially when they are used chronically. You should also try to improve in the functional status of a cardiac patient whenever you are planning for an elective surgery. Try to increase their inspiratory muscle strength, advise for aerobic exercise wherever possible, and also optimize their hemoglobin and albumin. So let's look a little deeper into the pathophysiology of sepsis in cardiac patients, especially when it comes to sepsis-induced cardiomyopathy. So it forms a vicious cycle. Sepsis affects cardiac and cardiac actually worsens the septic shock. So whenever there is sepsis, there is a release of lot of cytokines, which actually can lead to mitochondrial dysfunction and microvascular dysfunction, ultimately leading to myocardial dysfunction and leading to sepsis-induced cardiomyopathy is what we see. So this ultimately will lead to a vicious cycle that can go on. But as I said earlier, there is one thing which has the highest odds with perioperative mortality risk of sepsis. That is the right ventricular dysfunction. So it is always important you also assess the right ventricle when it comes to assessing the risk. So for the right ventricle, you need to assess the pulmonary resistance. The direct myocardial, you need to assess the volume status of the patients as well. And this ultimately is directly related with the highest amount to perioperative mortality, is an independent predictor of mortality, and ultimately your LV function most of the times in these patients is also dependent on your RV dysfunction. So sepsis and heart failure, as I said, it's always a vicious cycle that goes on. If your heart failure worsens in septic patients, the patients are going to go down. And if you have sepsis in a patient with decreased cardiac reserve, again the patient's condition is going to go down a lot. So this inflammatory triggers which leads to endothelial damage will then exacerbate any cardiac dysfunction which is already present. So how to identify sepsis in these cardiac patients, post-op especially. So what we have classically used is the SOFA scores to identify sepsis. So far we actually recently have the SOFA 2 score that has been published in JAMA in October and September. So they have made slight changes, especially when it comes to noradrenaline doses and the thresholds when it comes to hemostasis and liver. So this we can use, but this is for the general population. For cardiac patients, main thing is these lacks two important things, which are the blood pressures, lactates, heart rate. So these, when you look at the patients or with cardiac patients going into sepsis, the two main systems that are involved in all these systems are the cardiac and the renal. So we should be more careful in assessing these two systems when it comes to cardiac patients undergoing having sepsis. So the initial hemodynamic management when it comes to sepsis, the important part is always fluid. But that was the most difficult part to do in case of a cardiac patients with reduced function. So we talk about liberal strategy when it comes to sepsis, but for cardiac patients, we tend to be on the restrictive side. To assess the correct fluid responsiveness is the most important part. Speakers have already talked about dynamic fluid response assessments before me. You have bedside equipment, you have bedside ultrasounds now easily available even in intra-op period. So you can use this to assess dynamically, which are much better to correctly assess the preloads and afterloads and determine if the fluid you are going is going to improve the cardiac function or deteriorate it. Vasopressors. So when it comes to sepsis in cardiac patients, along with fluid, you always tends to start vasopressors as well simultaneously, because that will actually decrease your need of fluids at the same time, give some support for your heart which has especially dysfunction. Norepinephrine should always be the first line for the various reasons. The second line drug, that is where the key is, vasopressin is what is recommended, but you can individualize. For for severe LV dysfunction, you can use dobutamine. For RV dysfunction, whenever you have it, milrinone is actually a very good drug that can improve your pulmonary resistance. Coming to the initial antibiotic management, I will not talk about the antibiotic choice, but I'll tell you about how to give the antibiotics in these patients. So the most important thing is to actually calculate renal clearance in a cardiac patients. So what we use generally, the urine output or the creatinine to measure EGFR are very poor methods to actually calculate renal clearance in cardiac patients. The ideal way is to go back to the basics, calculate the urine, serum creatinine for a short duration, and that keeps changing actually day by day. So that is the best way to actually calculate renal clearance in these patients. Of course, you can use some other adjunctive tools like kinetic GFR and cystatin C if they are available. The pharmacokinetics, so while renal clearance is one part, with the cardiac patients you also have increased volume of distribution. You have the problem of underdosing when you have this increased volume of distribution. While you have sepsis, heart failure and diuretics, difficult to determine the renal clearance, and the renal clearance is also becomes very dynamic. So that is why you have the problem of underdosing, especially in the bolus doses, and maybe overdosing when it comes to maintenance doses. So it is very difficult to correctly identify the creatinine clearance and appropriately dose the antibiotics. But with also advancements coming up, there are also challenges coming up with antibiotics. So we have an increased use of extracorporeal therapies, the support systems that we have. The dosing for these extracorporeal therapies actually has to be standardized, that are becoming now more common. The problem is you also have antibiotic sequestration with these extracorporeal therapies. You will have obviously increased volume of distribution, and you need frequent dosings. So to summarize, what I want to tell is sepsis and heart failure, they definitely form a deadly vicious cycle when they are together. And it will be very good If you preoperatively optimize the risk factors and reduce the risk of sepsis in these patients, you need to adopt a very restrictive, at the same time dynamically marker guided fluid strategies. It is always better if you can use a kinetic renal clearance and find the right dosing for your antibiotics in cardiac patients. So, thank you.